Well, good evening, everyone. Thanks for joining. Welcome to the Rollins DC Presents, Rollins Responds to COVID-19. My name is Joy. I am the host for this webinar, representing the Rollins DC Alumni Network. Today, we are joined by two amazing guest speakers who are both faculty of the Rollins School of Public Health, as well as the front runners in responding to the COVID-19. Our first guest this evening is Dr. Jodie Guest. She's a research professor as well as a vice chair in the Department of Epidemiology. In addition to Rollins, she serves as a faculty for the CDC's Epidemiology Intelligence Service Program. Currently, she leads a COVID-19 outbreak response team in Hall County, Georgia, where high rates of incidence has been reported by the state of Department of Public Health. And she has been leading rigorous efforts from conducting virus tests, showing how to wear masks and distributing masks, as well as educating the community and family members in Spanish and English. Our next speaker is Dr. Ben Lopman. He's a professor in epidemiology, as well as an expert in infectious disease modeling. He has been doing rigorous work in the mathematical models to understand how COVID-19 is transmitted and how it can be controlled. And this work has been especially important in planning out to safely open the Emory University for this fall. And interestingly enough, his previously planned study has been re-evolved and retooled to be implemented on a study to address the COVID-19 pandemic. And this study is being implemented in the Atlanta for a number of companies, as well as the Emory building. That said, we are also joined by Jason Lee. He will be our moderator for the session with our guest speakers today. He's a biostatistician, data analyst, as well as a statistical programmer at the Johns Hopkins University. And he also serves as the member at large for the Rollins DC Alumni Network. So thank you all for joining. That said, I'd like to give out some information about the format for this evening. We'll start out with a brief presentation by our guest speakers, first by Jodie Guest, followed by Ben Lopman. Then we have 20 to 25 minutes time allotted for discussion with our guest speakers, moderated by Jason Lee. And during that discussion time, we have some previously submitted questions that will be brought up to our guest speakers, as well as any new questions that are submitted in the chat throughout the webinar. So if you have any new questions, please submit them via chat. You can hover down on your screen, and you'll be able to see a comment bubble. Click on that and please submit your questions, and we will get to those questions in the end. That said, I'd like to turn it over to our first presenter, Jodie Guest, for our presentation.
Great, thank you. Kind of be sharing a screen here. So making sure, can someone give me a nod that they can see my slides? Okay, great, thanks Ben. All right, so it is a pleasure to present to you today the work we've been doing since April 22nd in Hall County, Georgia, with Emory's outbreak response team for COVID-19. And I want to acknowledge that that outbreak response team didn't even exist before April 22nd. So this is a rapid set of information that you're seeing that was put together. Just to make sure everyone's up to date with the latest numbers for COVID-19, as of about 3 o'clock today, there were 9.6 million cases of COVID-19 across the world. And in the United States, there were 2.5 million of them. Just to give you some information about the scope of the US epidemic, 26% of the worldwide cases are appearing in 4.2% of the world's population. So the United States is bearing an inordinate burden of disease for COVID-19. The Georgia data also updated, I'm sorry, the date's wrong on this, updated today as well. We're approaching quickly 70,000 cases. And when I updated this from last week, it's staggering to see the increasing numbers that occurred that quickly. We in Georgia have about 2.7% of all the United States cases. The work I'm going to be showing you today that we've been doing is specifically in Hall County, which you can see here in with the arrow pointing to it. Hall County is right outside the metro Atlanta 5-county area. It is a population of right around 200,000 people, with about 13% of the population living below poverty level. And about 14% going with that also have no insurance. And 28% of the population is Latino, Hispanic ethnicity by their definition. So my work in this community all began when I got a phone call on April 22nd from the healthcare system saying that they had an outbreak in the poultry processing plants in Hall County, and they needed help with rapid testing and enhanced community outreach. They were already struggling with an outbreak, and then they had a very specific one that they were requesting support for. So we put together this team. These are 8 students who are in the epidemiology department. They are now rising second-year students, and myself, and the 9 of us now spend about half of our weeks up in Hall County doing a lot of this work. So our response has been multi-pronged. We mobilized very, very quickly. Within 4 days of the phone call, we were a unit, and we were already traveling to Hall County. We assist with pop-up testing, and we've been doing a lot of different forms of community outreach to make sure that we are really embedded in the community, that we've earned the trust of the community, and we are providing them with the resources that they need. So probably our most popular thing that we've been doing is our pop-up testing. And the purpose of pop-up testing is to provide COVID-19 tests, and to do that in very targeted communities in need. And over the course of the past 7 weeks, we've done 6 testing events. We've tested over 1,600 people. The range of positives at each of these events are anywhere from 5 to 30%. But I think the staggering number is that on average, 25% of all of the people who are tested in these testing events who are associated with the poultry plant are testing positive. Those are really striking high numbers. The other thing to know is we've married the community and programmatic support for the Latino population with some research components. And that is one of the ways we've been able to do this as quickly as we did, by validating 3 different testing modalities for COVID-19 that are all data that we're using to get FDA approval for different methods of testing. So if you've been tested for COVID-19 or have seen pictures of it, the standard of care is a nasopharyngeal swab, which is a pretty deep swab through the nose. And we are testing other ways to test for COVID-19. And so we're always comparing it to the standard of care to see if a saliva test or an anterior nares swab, which is in the front of your nose and not nearly as invasive, or a blood draw might be efficient to also test for COVID-19 and might be an easier method to test. We also had the opportunity through our relationships to start working with the school districts in Hall County. There are 2 school districts up there, Gainesville City Schools and Hall County Schools. Between them, they serve about 38,000 children. And by talking to the community and really trying to understand what was going on with the outbreak through all the community leaders, we learned that these school systems were using their buses and their bus routes to deliver meals, breakfast and lunch, to all the children who had been in school but were now going to school virtually. And they were going to continue that through most of the summer. So when you already have a delivery system that's in place that is getting out into the community that you want to get to, it's the perfect place to add on prevention messages. So you don't have to create anything new, you just capitalize on what's already there, and it's already a really trusted delivery system. So we started riding these school buses. And we started, at first we wanted to see what it really looked like. And we quickly determined that almost none of the homes that had meals being delivered had masks. And if they had masks, they weren't wearing them. They didn't have masks for children. And there was a lot of concern that no one wanted to wear a mask. So we immediately started on a public health messaging system where we said, no, masks are important. Here's why they're important. Here's how you wear them. So first we got 1,400 masks out in one day out to all of these homes. And then we went back the next time on the buses and they weren't wearing them. So we realized that it wasn't maybe that they didn't have masks, it was that we needed to talk about when you need to wear masks. And then we started seeing people pulling their masks down so they could talk to us. So it's kind of a 3-pronged approach of how to wear a mask. You have to have one, you have to put it on, and then you have to wear it up over your nose and your mouth at all times when you're outside. So we've spent a lot of time talking about that. When we began, less than 5% of the people who were coming to get their meals were wearing masks when they came to the meals. And additionally, not all of the staff members who were providing meals on the buses were wearing masks or using gloves. So we also did a lot of training with the staff as well. We created banners that now go on the buses. They're the same banners that are going to be used at the school systems as well. So we found it was just a really great way to get in the community, learn what some of the barriers to COVID testing were, and barriers to other forms of prevention. We also had the liberty of really seeing how the Latino population that we wanted to serve was living in Hall County. And what we saw were multi-generational homes, multi-family homes. And so it was not unusual to see a 2-bedroom, 2-bath home holding somewhere between 8 to 15 people. You saw living rooms with hammocks strung up in the living rooms. And so it became very obvious that in addition to needing to provide good messaging about masks, if someone in that home was tested as positive for COVID-19, there was going to be no ability to really isolate inside that home. So that brought up a lot of other conversations with the community leaders about where are we going to put someone when they're recuperating from COVID-19 so that the risk is not continuing among all of their household members. And the original idea was there was an empty jail and we could house everyone in an empty jail. And you might imagine that's not a very popular idea, particularly when you're talking about a very vulnerable population where there are already going to be concerns about immigration status and safety at testing events. And so we worked with the Hispanic Task Force and the Chamber of Commerce to come up with other ideas, and including changing the name from an isolation and housing unit to a recovery unit so that it didn't feel so isolating and didn't carry such stigma associated with it. So now we have RV units that are inside apartment complexes, and we've trained community leaders to provide the care for those RV units. And so now it feels like a very community supported way of taking care of their own if they test positive for COVID-19. Excuse me. So just to give you a little bit of idea of the numbers, just in the month of May, these 8 students spent 580 hours on site in Hall County doing testing events or riding school buses or working with the task force or the Chamber of Commerce. So this is a really intense amount of work, and it requires a lot of travel, and I just want to show you how hard these students have been working. I want to show you what we're doing next, because Emory received a really wonderful grant from the Woodruff Foundation to provide support across the entire state for COVID-19 outbreaks. That is one of the 4 components of this new collaborative, and it's the part that I will be working on. So now we want to look beyond Hall County. We don't want to leave Hall County, but we want to look beyond it. And we've got a great number of hotspots that we should be watching in the state of Georgia. So I just want to give you a moment about all of that. These counties are not listed in alphabetical order. They're listed in north to south across the state. And these are the counties that I'm going to be working in starting as early as Sunday. So Hall County I already told you about. That is primarily a Hispanic poultry plant outbreak. Gwinnett County, which is the very next county below Hall County and one of the metro Atlanta counties, is also an outbreak that is rising rapidly. And it is an outbreak that is not specific to the Latino Hispanic community, but it is an outbreak that is happening in the Latino community, and they're not coming to get tested at the rates we would like. And so we're going to go there and start doing pop-up testing and taking a lot of lessons that we learned in Hall County and bring them into Gwinnett County. Then when we move into the middle of the state, Hancock County and Baldwin County, which is near Macon, we start to see a shift in what the outbreak looks like in Georgia. And so I want to be clear, anytime you look at a state, you probably have multiple mini outbreaks going on, and they're not all the same, and they don't all need the same sort of response. And even within one county, one response does not fit all. So Gwinnett County has a very large African-American outbreak. It has a very large outbreak in general, but the Latino community is the community that we need to help serve because they're not getting into testing events. Hancock and Baldwin County are primarily an African-American outbreak that we've got going on. Hancock County was specifically started in a nursing home and is seeded inside the community and is just spread to very, very high rates of transmission. Then we move into South Georgia, and South Georgia goes back into a primarily Latino outbreak or driven outbreak, mostly based on the agricultural workers that we see in South Georgia. So these are seasonal and migrant workers. Some of them are going to stay for most of the summer. Some of them are going to stay for about 6 weeks. And there's been a lot of testing that's being done in these farms and these communities. These are communal living situations. They ride buses together to the fields to pick. There is zero ability to isolate in these populations in South Georgia. And when you look at Eccles County, which is the very bottom of the state in pink on this map, they are finding rates of over 4,500 per 100,000. That is a staggering rate of COVID-19. And when they go into particular picking farm areas, they're finding rates of 70 to 80% in each of their testing events. So really monstrously high testing numbers. And that community is going to migrate soon out of the state of Georgia, and they're going to be in North Carolina. So all of a sudden we need to start talking about state to state conversations about, here's a population that's coming to you and we already know their testing status, but they need follow-up to know when they're no longer testing positive. And then we also need to be watching all of those who are not positive yet, but have been living with them to see when they're going to test positive. So just giving you an idea of what's going on in the state of Georgia and some of the numbers. Lessons that we learned real fast are up at my part. I talk all the time with my team about, we have to talk about who is at risk. We have to talk about what's driving that risk. These are not genetic risks per se, although there are a lot of comorbid conditions, but a lot of the risks I've talked about are about demographics, and they are systemic inequalities that have been generational in nature, and they're really showing off how much risk these communities have, and COVID-19 is taking advantage of it. We also want to talk about our prevention messages working. What I think might make sense may not make sense in another language, may not make sense with other cultural differences. And so we always want to work with the community that we are hoping to support to make sure we're doing it in a way that's very culturally competent and very sensitive to the specifics of the community that we're working in. And we want to bring the community in. We want to ask them what they want. We don't want to assume that we know what they need. And so this picture is us working with the healthcare system in Hall County. And it's just really important to make sure that we don't come in and say, hey, we're the experts, we know what we're doing. We want to say, hey, let us help you, but please guide us and show us what we need to know. And so with that, I will leave you. Here's my team, not in their PPE, and I just can't say enough about what our upcoming public health professionals are doing for the COVID-19 response at Emory. They're amazing. And so it's a privilege for me to get to show you a little bit about what they've been up to. So with that, I'll stop sharing my screen and pass it on to Ben. You're on mute, Ben.
There we go. Terrific. Good evening. Good evening, everyone. Thanks for that, Jodie. I've been following the work that you've been doing, but not in that depth. So it was terrific to see what you've been up to, and nice to see you. We see each other occasionally on Zoom calls, but
I know I miss
interacting in person. And nice to see some familiar names at least on the list of attendees. And so thanks for having me. I'll do something a little bit different, which is to give kind of an overview of some of the work that my group has been doing. and it's going to be a lot nerdier than what Jodie just showed you. I won't go into any kind of any depth on anything, but I just want to give a sense of some of the studies and that we've been doing to try to get an understanding of what's going on with the epidemiology of COVID-19. Some of the work specifically directed at Georgia, and how we've turned the ship of our research group to refocus to work on some of these questions. So my I guess my day job, what we used to work on back in the pre-COVID era, is mainly enteric viruses. That is, viruses that cause stomach bugs, cause diarrheal disease, like rotavirus, like norovirus, and also some more kind of fundamental questions about epidemiology. And so we've kind of turned the ship and redirected that work, a lot of that work over the last few months, to work on COVID. So here's the team. I want to, like Jodie did, sort of recognize that what I'm going to show you is really the work of a terrific group of master students, doctoral students, postdocs, and other staff who are on our team at the Rollins School of Public Health, who have been really remarkable in kind of keeping their research going, their lives going, and also taking on this important task to kind of refocus our work on COVID. This is I have much of my career tried to kind of avoid working on outbreaks and try to focus on endemic problems, because I've always felt that endemic problems are the things that are often ignored because they're sort of with us all the time. But this outbreak, this pandemic, is clearly something different and deserves all of our attention. And so we've really shifted our work to focus on it. This picture is, of course, a little bit out of date since we can't all get together for a group photo these days. Okay, so I'm just going to give a quick overview of a few different things that we're working on. And hopefully I'll just give you enough of a flavor that if there are questions, if you want to know more about any of it, we can talk about it in the Q&A that follows. So one thing we've been very interested in is how serological tests could be more helpful in the response. So the kind of testing that's generally done, many of you will know this, the kind of testing that's done for diagnostics is looking for the virus itself, kind of viral testing, which is the kind of testing that Jodie that Jodie's team is doing in their outbreak response by and large. But there's these other tests, which many of you will know about, these antibody tests or serological assays. And this tells you not whether someone is infected at present, but whether someone has been infected at some point in the past. Now, hopefully, that also means that that person has a degree of immunity. Now, there's a lot of questions around that. What do those results actually mean? But we think that it means something, and the fact that we aren't seeing a lot of people getting reinfected. In fact, I don't think there's any credible reports of reinfection. Gives me optimism that those are telling us that people have a degree of immunity. So what we've been, one of the projects we've been doing, this has been led by some postdocs and actually soon to be faculty member in our group, a postdoc Alicia Cray and Kristen Nelson. We've been developing models to look at, what if you could test a large part of the US population or do a big serological study to figure out how many people have been infected? Could you use that information to kind of release those people from social distancing or let those people work in the front end of healthcare? And we think that, our models suggest that that you can do that. You need pretty high, you need a good assay, you need a good test, and you need to do a pretty good amount of testing in the population to identify who's actually been infected. But we think that, that antibody test can do more than just tell us where we're at in the epidemic, which is traditionally what they are being used for. So that's one project. And I'll also mention that this is in collaboration with someone named Joshua White, who's a professor at Georgia Tech. So we have a really close collaboration looking at this issue with him. So the second project is something that's been done in collaboration with the Georgia Department of Public Health. There's actually a really large kind of ongoing collaboration, a set of collaborations between Emory and GDPH, looking at a whole range of different activities. And our sort of specific subgroup within this GDPH Emory collaboration is to look at, what we're doing is looking at the transmission dynamics. And this is a project that's led by another faculty member, Max Lau, who's pictured here, which we've been trying to calculate or estimate R, the reproductive number, which is something you've probably heard a lot about over the last couple of months. And this is this estimate of essentially how the epidemic is spreading. R, for those who don't know, is basically the number of how many people an average person goes on to infect. And so if that number is greater than 1, you have a growing outbreak. If it's less than 1, you have a shrinking outbreak. So this is, again, an analysis we did with GDPH data from a couple of different counties. And again, I'm not going to go into any detail here, but the kind of blue part of this picture for each of the counties is what the R was before the shelter-in-place orders came into effect, and the red or pink is the R value after the intervention, after the shelter-in-place orders. So you can see it dropped a lot and came down right around 1, and 1 is exactly what you'd expect it to be if we were kind of at a stable situation, which in terms of reported cases is where we've been. At least that was the case until last week or two when we started to see an increase. So we're continuing to monitor this. As you could imagine, this is really a critical value for us to understand where the epidemic is in Georgia. So 2 last projects I want to briefly mention, and this is one that Joy noted in her introduction. So we were, I think this is happening at sort of universities around the country, maybe around the world, that administrators and leadership are asking their infectious disease faculty to help them to think through what transmission might look like on campus, what the problem might look like, and what we need to do about it if we do indeed open up in fall. So to sort of help our leadership at Emory Healthcare and Emory University to think this through, we built a mathematical model, which sort of describes transmission of SARS-CoV-2, of COVID on campus. And we use this to estimate or to look at different scenarios of how if we had an outbreak on campus in fall, how it might progress, and what we can do to control it. And specifically what we looked at is how we can bring diagnostics to sort of initiate control. So if students or staff or faculty have symptoms, they can come forward and get tested. And when they get tested, if they turn out to be positive, they become isolated. Their contacts can be traced and quarantined. So all of these things will be put in place on campus. And so what we did was to sort of build this model to think through both what the health impacts might be, what the health risks are, and also what the university needs to do in terms of capacity. How many isolation facilities do we need? How many tests do we need to be prepared to perform over the next couple of months in order to open up as safely as possible? So we have a paper on this that's on an archive if you want to have a look at it. But we thought that this was going to be potentially quite useful to other universities who are dealing with this problem, this decision. So we built a web-enabled version of this model, and you can go and play with it if you want. It's at the link here. And so you can come into this and you can sort of change a few things about your, to represent your campus. You could change the number of students, number of faculty. Maybe you could turn up or down how transmissible you think the virus might be on your campus. And you can use it to, we hope university administrators, others will use this to help with their planning. And should say this, the web front end was built by a colleague of mine, Sam Janess, and a terrific programmer, Adrian Legouillot, who's working with his group. So we did, we stood this all up really, really quickly, as everything has to happen in the COVID era. And the final project I want to mention is something really interesting, and again was an example of work that we had to really repurpose in the age of COVID. This is a project to look, kind of asking a few more basic questions about how infectious diseases spread. This is a study about how people mix together, how social mixing occurs. We actually have a couple of different studies ongoing, and they're all in collaboration with Yale University, my collaborator, Saad Omer, who's now the director of the Yale Institute for Global Health, who was a faculty at Emory until last summer. And so this specific project is looking at how people mix within US workplaces. So we are having people complete diaries, and actually when they go back to their workplace, we're also going to have them use these electronic tags, the kind of tags that you use when you enter a building. People will be asked to wear these when they do come back to the office to register how frequently they're coming into contact with others, so we can get a sense of social mixing. And clearly this is critical. This is how respiratory infections spread. And so this was supposed to be a study about pandemic flu. It was going to be quite a hypothetical exercise, but there's nothing hypothetical about it anymore now that we're dealing with a real pandemic. And so the kind of data that we get from these projects are what you see on the left panel of the screen. This is a kind of a heat map, a matrix of the intensity of mixing, and what's cut off here is this kind of age of a contact and the age of a participant are the different axes. And so you can see there's kind of a diagonal there. People tend to mix with people in their own age group. And I'll tell you some very interesting, maybe not surprising, early results from one of these studies in the U.S. is that contact rates, of course, have plummeted. People, on average, before the COVID era, had something like 14, 15 contacts per day. Our studies are showing it's more like 2 right now on average, and those are all probably like they're mainly in households. At least these are people who could telework. They're household contacts, and they're repeated contacts. So people, at least those people who were office workers, are probably having kind of very small kind of networks of contact right now, and maybe that's going to change as office workers at least, go back to the workplace. So this is again a collaboration. We have a large team working on these studies. In fact, I think one of the participants of the call is going to be joining this team soon. So we're excited about that too. And with that, I'll stop. I know I didn't go into any detail on any of these projects, but wanted to give you a kind of flavor of how we've redirected some of our work, and happy to talk more about any of it. Thank you.
Well, thank you, Jodie, and thank you, Ben. Both, very, very enlightening talks here. And I've got plenty of notes here on the right side of my screen, as well as a host of questions that were submitted prior to today. So just again to reiterate from what Joy said at the top, if you've got any questions, please feel free to throw them in the chat on the right half of the screen. You can get to that chat if you're on a PC by going to the bottom bar, clicking the word that says chat. If you're on mobile, I'm not as sure how to do that because I'm typically on Zoom through my PC, but I believe you can swipe to a chat screen, or it might be an option for you if you tap on your screen. So please feel free to send those in, and we'll be monitoring that chat over the next 20 minutes or so. So Jodie, I'll start with a couple of questions for you. You talked quite a bit about testing and about testing capability. So I'd like to ask a couple of questions about that. First of all, what does a typical test day look like for you and your team? How many people are typically coming through? How long does that testing process take? What sorts of things are involved there?
Oh, great question. And I'm getting ready for one on Sunday, so you should see what my spreadsheets look like. Testing events are typically, we've been running them 9 a.m. to 5 p.m. And so that's an arrival by like 7:30 to start setting up. Because we're Popup, we bring all of our own facilities with us. So we bring in tables and chairs and tents. And so it's thinking through, how many testing stations am I going to have? How do we do our consenting? Do we need power? We've been doing a lot of video consents so that they are, because most of our consents so far have needed to be in Spanish. And it is an easier method when you've got low literacy and it needs to be in a primary language of the participant. It's been a lot easier to do video consents. So we need to think about power sources and things like that. And so we're hauling everything up. We've become good friends with U-Hauls. And we typically run like 4 people consenting and 4 to 5 stations of testing. And then there's a checkout section as well to make sure we have all of our paperwork in line. And it's hot. We have to bring all of our own PPE up there, so everyone gets trained on how to wear it. And depending on the type of testing we're doing, it changes if we need a face shield or if we need an N95, or if we're fine with a face mask and a face shield. So there's some differences with that based on what testing we're doing. So everyone is just slightly different. What we have been struggling with lately is the heat. We're always on asphalt and you're in these non-breathable plastic suits, and they're non-breathable to protect you, but they're also incredibly hot. And so we've had to do some learning on the spot as we've had our staff members faint from the heat. And so we've had to start rotating, okay, every X amount of time you're out and you're gonna go sit under this tent or go sit in a car and get air conditioning, et cetera. Depending on how many tests we're doing, we can run, we've had as many as 250 people in a day, and that is wild and really, really busy. We're taking about 26 people with us every single time we do a testing event. And that's a ton of people. And the day we had about our maximum number, we also had a storm in the middle of our testing thing, and tents were flying over and paperwork was flying everywhere because the storm came up really fast. And so when you're chasing consents across the parking lot as well as your tents, it's a wild day. And we still tested over 200 people that day. So you never quite know what's going to happen.
For sure. Yeah. Growing up in Florida, I'm well aware with the afternoon thunderstorms. So
yeah.
Glad to know that it is not unique to there.
No.
You mentioned quite a bit, these experimental swabs and these experimental, tests. Oftentimes what I'm seeing in the literature is kind of a mixed bag regarding, these experimental swabs. So, I'd like to ask you, kind of what's the sensitivity and specificity look like for some of these experimental swabs?
Sure.
How are you guarding against not only the false positive test, but I think more importantly in this case, the false negative?
Yeah.
Right. Where we might tell somebody, "No, you're good," and in actuality, they're really truly positive.
Yeah, that's a great question. So every time we do a research, we're validating a new research testing modality. We are always also doing the clinical standard of care. So that we've always got a nasopharyngeal swab that goes with any other testing or any other test we're trying to validate. And we're actually returning the clinical specimens. So that's the nasopharyngeal swab. So when we were first doing anterior nares testing, which is the front of your nose, we were doing that and a nasopharyngeal swab. And then only the nasopharyngeal swab was returned. Now anterior nares are considered appropriate clinical specimens by CDC. So now we've moved to that being our standard of care because it's a lot easier to do. It's a lot more comfortable. And we're comparing everything to that. So we did oral pharyngeal swabs at the beginning, and FDA did not like our data on them. We had someone vomit when you stuck the swab in the back of the throat, and FDA quickly said that it's going to be a no-go on that one. Saliva tests have been looking a lot better, but it seems to be highly variable depending on how you collect it. So we've done a couple different methods. So if you are collecting saliva from way back in your throat, it's different than if you're collecting it from just a spit in the front. And so we've been playing with that. Anterior nares are kind of our, that's what's won our prize so far. That's our best test. And we're thrilled the data was accepted by the FDA for that.
Awesome. Great to hear. I want to turn testing over to you, Ben, because you mentioned antibody tests quite a bit. So, just a question that I've got here. What sort of performance are we getting from antibody tests now in terms of the false positive and false negative rates? What sort of rates do we need to get to in order for something like what you showed to kind of come into practice, and what needs to be done, in the lab to kind of ensure that?
Yeah. Thanks, Jason. That's a very important question. So first of all, the concern with antibody tests is kind of the opposite of diagnostic testing, of PCR testing. The big concern is false positives. So telling people that they have been previously infected, maybe then they think they have immunity and going out and, not protecting themselves. So there's a bigger concern if someone, gets a false positive test and thinks they're immune when they're in fact not. The accuracy of the performance of the assays has improved a lot over the last couple of months. The first FDA kind of cleared assay had a 96% specificity, which doesn't sound so bad, but for those of you on the call who took Epi 1 with at Rollins, you'll remember that that the positive predictive value is changes depending on how the prevalence of the disease. In this case, how many people have truly seropositive, how many people have been infected in the past. And we think that number is probably less than 5%. So that means that with like a 96% specific test, half of your positives will be false positives. So it would be very concerning. All that said, the performance of the assays is improved a lot, and there are now assays that report 99.8% specificity. And then there's, in addition to just improving individual assay performance, there's kind of algorithms people use. So you test, and when you get a positive, you go and test with a different assay. And so that's another way to kind of improve the accuracy of your kind of testing algorithm. And that's what we're doing now in some large scale serosurveys that we're involved with.
Sure. Yeah, great. And just a quick follow on to the false positive thing, and potentially allowing people that are not truly immune. Do we know anything about immune folks possibly being carriers? I would consider that to potentially be a huge problem if we think, I can let an immune person out, but they can still spread, from person to person, either through contact or something else.
Yeah. No, that's an important point too. So I think in practice, if you were to implement this kind of strategy, like in a healthcare facility, for example, and you could identify people who had antibodies, you would probably then want to also perform PCR diagnostic to make sure they weren't actually shedding. In addition to that, though, I think by the time about 10 days after infection, you'll develop antibodies. And it looks like even if someone is shedding virus, and that is, you can still detect virus or still positive after, let's say, 2 weeks or so, it looks like that's not infectious material anymore. So that people are doing these kind of infectivity assays where they don't just see if you can detect virus, but actually, is it infectious material? Can you sort of grow it in cell culture? And it looks like after a couple of weeks, people are not infectious. I wouldn't say there's no risk with any of these strategies, but what we need to think about is how we can kind of use all this knowledge that we're gaining to reduce risk, right? And so I think all these things are still worth pursuing and exploring.
Great, thanks. Jodie, I'll come back to you. There's a question here in the chat on mask wearing, yeah. And I've got a larger kind of question that came from before today regarding stigmas. So I'll kind of ask a three-part question here.
Okay.
What are some of the barriers for people who are not wearing masks consistently? And then what are the best ways to overcome those barriers? And then kind of same question as it relates to testing. Are there any stigmas associated with just going and getting a test itself, and what needs to be overcome there?
Sure. So barriers to mask wearing, first you have to have one. And so we've been working with a lot of communities that don't have necessarily the resources to get one. And so you have to make sure you're really helping provide them where needed. And then, as I said earlier, we've seen a lot of people wearing masks inappropriately, and they're starting to all get names, like people that pull them down under their chin, and they all kind of have these new social media names that people are giving them for inappropriate mask wearing. And I think one of the best strategies for good mask wearing is our leaders need to be wearing masks. And I don't know how else to say that more strongly, but we need to show people that our leaders are wearing masks. And so when you see people in the Senate or whoever you're watching on TV, if they're near other people and they're wearing masks, they're modeling great public health behavior. And that's really important. And they're also modeling that you can speak through them. So some of the very few public events I've been to for some work here in Georgia, the leaders take their masks down every time they want to speak, and then they put them back up. And so it's got to be that consistent. You can actually speak through these things, and we can hear you. And so I wish we could get all of our state and local and country leaders to be doing that. I think it just is such an important message to have out there. In Hall County, the Hispanic Business Alliance came together, and they put on their own promotion and said, no mask, no business. And so, carrying on with that, no shirt, no shoes, no business, they added masks to it, and they are doing it. They are not letting you through the door. And what they've said is, it's not to protect you, it's to protect my employees. And I need to stay open, and my employees' risk is substantially different than your risk as you come just for a few minutes through my store, but my employees are there all day long. And if you can get businesses to buy into it's protecting their employees to do it, I think you're going to have the economics behind mask wearing and and ask people to do that. What I do know is mask wearing has become a political divide, and that is super unfortunate. Public health should not be like in the bottom of politics. It should be above politics. And so it's very unfortunate every time I see that we can almost map out mask wearing by voting practices, and that is a sad state of affairs.
Yeah, couldn't agree more. There's actually a case of that I saw just on media reports in the last 24 hours from Palm Beach County, which is, I would think, a place where people would be more willing to wear masks. And the conspiracy theories that were being spouted were something. If you've not had a chance to look at that, I encourage you to go watch that and enjoy it with a beverage of your choice, because it is something.
I think one of the beautiful things about our country is our freedoms. But we also assume that means that we don't have a ton of social responsibility sometimes. And I think that this has gotten caught in that. And that you asking me to wear a mask is you taking away a freedom of mine. Mm-hmm. And I'm perplexed by that philosophy myself, because we don't feel that way about seatbelts. And it seems like there should be some ability to make some connections between other public health preventions that have been put in place that people have not rallied against. What we know is that public health prevention over the years have substantially changed our life expectancy. This is just one of those as well that is meant to be helpful. It's not meant to take away anyone's rights. And we actually would be more interested in people being out and about if they were wearing masks. So it really is kind of not in your own best benefit to not want to wear one. Yeah. As far as stigma for testing, I can speak specifically to poultry plant workers. There are some poultry plants in North Georgia that if and when you test positive, you're going to go home and you may not have a job anymore. That is a really strong statement about protect your economy and your personal pocketbook and don't get tested. That is the wrong message to be giving. I've had the pleasure of working with a gentleman in Hall County who is the only Hispanic owner of a poultry plant. And I'm so incredibly impressed with him. He not only has asked all of his employees to get tested on the clock, which there's some issues about employers requiring. So he's not requiring, he's offering it, and he's paying you your wage while you're getting tested and waiting in line. And then if you're positive, this is the part that's so beautiful. It makes it, I think, appropriate. He's giving you full sick leave with pay. And if someone in your household tests positive and you need to stay home, he's giving you 75% of your pay. So he's really kind of put his money behind, I want to know because I'm going to protect you. And so if everyone were supporting their employees like that, I think the stigma would go away. But if you're potentially going to lose your job by being tested, people are choosing not to get tested in that situation.
Yeah, that's an awesome thing to hear that's happening, and really hopeful that kind of of thing continues to happen, not just here in DC, but for the most marginalized in the community. Speaking of work, I want to touch on that with another question that was submitted earlier, and I'll put this to both of you, Jodie and Ben. Jodie, in that previous answer, you had talked about people coming in to the workplace, customers, for instance, coming into a store without a mask. And, we're seeing quite a bit employers facing pressure to test employees, right? Whether that is through antibody testing or through, the actual nasal swab testing. The EEOC just clarified actually that the Americans with Disabilities Act, the ADA, prohibits employers from using the serology tests for determining which employees can enter the workplace. So, in light of both of those things, what do you all think is the best approach for employers for ensuring a safe workplace? Is it through test, trace, isolate? Or is it through social distancing and increased cleaning and things of that nature? Some combination of both, and if so, how would you weight that combination? And I'll ask either one of you to answer. It doesn't really matter.
Ben, you want to go first?
Sure, I can go first. And I've been thinking about that question broadly, but mainly in the context of Emory University opening, because I've been in part of those discussions. What Emory is going to do is, first of all, require face coverings, which I think is good. It's important, and it sends a signal. Like Jodie said, this is maybe it's in some level an individual choice, but there's a lot of, I think, signaling and peer pressure in a good sense involved in this. And when you're part of a community that's all wearing masks, it's much easier to do it. One of the things we looked at in our models of safe return to campus is the trade-off or the different strategies of what we call screening, basically testing everyone with some frequency, whether they have symptoms or not, versus doing good surveillance, asking people to come forward when they have symptoms, educating them what the symptoms are and what to do if they have them, and testing people, then having them isolate, trace their contacts and quarantine their contacts. And what we find, even under kind of pretty pessimistic scenarios of transmission on campus, which I think is going to be a riskier environment than the average workplace in a lot of ways, we find that kind of strategy, if implemented reasonably well, can stop transmission. Right? And it's not to say you won't have any cases, but you can stop transmission with basic public health. Our sort of classic kind of bread and butter, surveillance, testing, contact tracing, isolation, and quarantine. We've seen that work in other countries, and maybe Emory and some other employees can be like some of those countries and have an effective public health response to contain transmission.
I don't have anything to add. That was perfect.
Great. I do want to be respectful of time here, and I know we're coming right up to the top of the hour, so I'll just ask maybe one more question to each of you. There are a lot of questions that have come in, Jodie, in the advance here about kind of the politics of this, and you talked quite a bit about that in your last answer. How are you communicating, if you are, with people that think that this is a hoax, and what kinds of persuasion techniques can be used among those folks? And then are you seeing any sort of misinformation in the prevention? Anything that you're seeing out in the field, and what would be the best way for us, here in DC to kind of help tackle that?
So you should see my Facebook feed if you want to know about misinformation and combating it. I actually see more of it on social media and actually on the media than I have seen in the field. In the Latino population I've been working in, there is not a ton of misinformation. There's a dearth of information, but the information they have is not wrong. They just don't have as much. And so I've actually been working a lot with the television stations, because Telemundo and a couple of the TV stations that are most commonly going to be consumed by the population I've been working with are actually showing Mexican data, or data from Mexico, or are showing US data in general, or maybe Georgia data. They are not showing the data from their community. And so they're hearing it's okay, we're opening up, or Mexico doesn't have a big problem. And so it's not specific. And so we've been working a lot to try to get experts on those television stations, providing them very community specific information. As far as like the people who are on my Facebook feed, sometimes I have to take a break because it feels like it's a full-time job to combat bad information, particularly 2 months ago. But I've constantly just tried to put out good pieces of information from trustworthy sources, make sure everything's referenced. And when something super inappropriate is going around, I've talked about it and said, here are the reasons why the data doesn't support that. We also have gotten ourselves into a bit of this pickle in public health, because we originally said no face masks. We originally said it's only 65 and up that we should be really concerned about. And that was the right information then. And I think Dr. Fauci is now kind of given us some insight of no face masks was actually to protect PPE for healthcare providers. So there were some strategic decisions, but the original data that came out definitely showed all of your death rates were substantially different in 65 plus than they were below 65. Accurate at the time. We now have more information. We now have millions of additional pieces of information. So you have to be able to translate that into new information, but we have to recognize that some of this we kind of dug ourselves into.
Yeah. Agreed. Okay. Great, thank you. And one last question for Ben, real quick. You talked about the R0 study quite a bit. This is something that's near and dear to my heart, as I'm doing quite a bit of international modeling in humanitarian response countries. So we care a ton about R0. And one of the things that we were actually talking about in a meeting today was the effectiveness of non-pharmaceutical interventions, or NPI. So you showed the diagram there showing before shelter in place, after shelter in place. Look at the difference in the R0. Do we have any way, at least here in or where you are in Georgia, or here in DC, here in the US, to measure compliance to that shelter in place? And can we get any sense of what the true effectiveness of what such an intervention, even shelter in place or otherwise, might look like based on the compliance figures that we think might be attached to them?
Yeah, that's a great question, and I'll give only a brief answer since we're over time. But that question deserves a long answer. I think, well, for one, like Jodie said, with the accumulation of new information, new data, we're learning about things that truly are protective, that do work. And for example, face masks work. And so, when we get information we get data on compliance with masking, we can get some insight into how much that reduces R value in a community. We also, like in the kind of studies that we're doing, we're going out and asking people about their contact behavior directly. That's the most direct information you can have about potential exposures, is asking people about the number of contacts they have and a little bit about those contacts. But that data is obviously much harder to collect. What people are using as a proxy for that is mobility data collected from either cell phones or, mainly from cell phones, but either through kind of Facebook data or movement data tracked by GPS on cell phones. And, there were major reductions in mobility during the shelter-in-place period in Georgia and elsewhere. Maybe not as much as you would expect, but very clear decreases, and different decreases depending on locations people were going to. So people stayed home more, people went to work less, they actually went to parks a little bit more. And so, people are using that kind of information to also get a sense of the contribution of mobility, of contact patterns, of hygiene and PPE to the contribution of the reduction in R0.
All right, well, I know we're slightly over time, so Joy, I'm going to turn it back over to you. Thank you very much to Jodie and Ben. Appreciate it.
Jason.
All right, thank you, Jason. Well, first and foremost, I like to express deep gratitude for our amazing speakers today, Ben Lopman and Jodie Guest. Thank you so much for taking your time out of this evening to talk about your experiences, your work, and knowledge in responding to the COVID-19. I think we have a lot of information to think about in terms of our behavior, even in our personal lives today. And thank you, Jason Lee, for volunteering your time this evening. It was a wonderful discussion. I really appreciate you taking us through further in terms of having some thought-provoking ideas and breaking down some of those complex questions into equal parts for both of our presenters. And I'd like to thank everyone for joining this evening. And thank you for bringing up submitting those questions prior to this webinar as well as during this webinar. And that said, I hope you all enjoy the rest of your evening. Please stay safe. Please stay well. Please wear your masks. Good night.
Good night, everyone.
Thanks.
Thank you.